Hello and welcome to today's Talking Point presentation. I'd like to start by acknowledging the traditional owners of the land which we meet and pay my respects to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander people who are with us today or who may be listening in the future. My name is Dan Lubman. I'm the Executive Clinical Director at Turning Point and Professor of Addiction Studies and Services at Monash University, and I'll be facilitating today's Talking Point. Can we really change behaviour at a population level? The community that care approach to preventing and reducing drug and alcohol-related behaviour in Australia, which will be presented by Dr Bosco Rowland. For people that don't know, Talking Point is our regular series of public lectures designed to inspire, inform and challenge how we think about addiction and its impact across society. We'd like today to be as interactive as possible, so if you're joining us online, please pop your questions into the Q&A button, which you can see at the bottom of your Zoom screen. We'll gather them up and Bosco will address them at the end. And just a reminder that today's session is being recorded and will be available later on the Turning Point website. So I'm delighted to introduce today's speaker, Dr Bosco Rowland. Bosco is a statistician and senior research fellow with the Eastern Health Clinical School at Monash University and here at Turning Point. His research focuses on how social and behavioural principles can be applied to real-world public health problems. He's examined behaviours that shape health, social and emotional development, and the role of risk and protective factors both in Australia and across countries such as India, the USA, the Netherlands, and throughout the Asia Pacific. Today, Bosco will be talking about the Communities That Care approach. Communities That Care is a community-led, evidence-based prevention system that's been implemented around the world for more than 3 decades. It works by bringing together schools, families, community groups, and local leaders to identify what's driving alcohol and drug use in young people, and then tailoring prevention strategies to those needs. It's important that we talk about what prevention looks like. Too often, our health and social systems only respond once harm has occurred, in emergency departments, in hospitals, or in the justice system. But if we can intervene earlier and build environments that support young people and families before problems take hold, we can change trajectories. Prevention not only reduces harmful alcohol and drug use, it also boosts mental health, school engagement, and overall community well-being. It's a reminder that real lasting change is possible, not just for individuals, but for whole communities. And it gives me great pleasure to welcome Dr. Bosco Rowland to present his talk now. Welcome, Bosco.
Thanks, Dan. Oops, I'm getting movement here. Thanks, Dan. It was a nice little abstract summary of what I'm going to present. So I'll move straight ahead into things. I'm going to cover quite a number of things. Here's an overview. First thing I'll cover is what is Communities That Care. And I'm going to use the acronym CTC because it's a bit of a mouthful, but usually generally we prefer to refer it to as Communities That Care, not just CTC, but I'll call it CTC throughout this presentation. How popular is CTC? How is CTC delivered and implemented in Australia? How does the program supposed to work? And what's the international and national evidence? And then after that, we're moving forward in Australia with tackling the mental health problem. So what is CTC? Sometimes people refer to it as a framework that creates systems change to prevent poor and improve child and adolescent health and wellbeing outcomes in the community. So sometimes people talk about it as a noun, as a thing. Some people sometimes also talk about it as a process, as a verb. So Communities That Care is a community change process that benefits children and adolescents in your community. It brings community stakeholders together to make joint decisions based on local data. Oops, I'm just going to move this. And works to change conditions to promote well-being across the community. So there's a number of ways to think about it. Think about it as a framework and think about it as a process. So it builds on a number of disciplines. It's not just a silo-operated framework and process. It uses the learnings from social work, public health, psychology, education, medicine, criminology, and organisational and community development. What it's trying to do is use those learnings and understandings to prevent what we often call in the literature problem behaviours. So antisocial behaviour, school failure, so it's not school completion, dropping out of school, the use of illicit substances and the use of licit substances, youth violence, and depression and anxiety. So in terms of building and understanding this framework and process, it's important to recognise where it's come from. Isaac Newton, when he talked about at the end of his life the great work that he achieved, he said he only saw further because he stood on the shoulders of giants. I think when we work in prevention, we work in systems and service delivery, and we work in research, it's important that we don't forget about what we've learned and what we can learn from the previous people that have preceded us. So in terms of CTC, the key players were Professors Rico Catalano and David Hawkins, and Rico's there on the left and David's on the right. They originally worked in social work at the University of Washington and set up the Social Development Research Group at the University of Washington. And their work really kicked off with this article, Risk and Protective Factors for Alcohol and Other Drug Problems in Adolescence and Early Adulthood, published in Psych Bulletin in 1992. And you can see there, now that article has been cited 1,800 times. Now, any article that's cited 20 or 40 times is considered to be in the stratosphere. So 1,800 times is sort of beyond comprehension. And in that article, what they did for the first time was really summarise all the high-quality longitudinal evidence and identified risk factors that were precursors or antecedents to adolescent alcohol and drug behaviour and problem behaviour, and protective factors. And they organised them into sort of layers of influence, like the individual and the peer, the family, the school, and the broader community. And they identified when they would intercede or have the greatest impact across the developmental life cycle. And they were also first to articulate that risk factors are cumulative and additive, that the more risk factors someone's exposed to, the greater the risk. And they add on as we don't attempt to address them. So they often use the analogy of children and adolescents in a snowstorm exposed to all these risks. So what we've got to do is try and reduce or prevent or stop those risks. Or we give them a coat to manage in the snowstorm and give them protective factors to protect them from those risks. So their way of framing this really set up the foundation for communities that care and the work that it does. And that was early in the late 1990s. And then, of course, this man here, John Timberoo, worked closely with Rico Catalano and brought the program to Australia. He set up a not-for-profit company to use that as a way and a process for delivering and offering communities that care framework to communities or local government areas in Australia. And consistent with Catalano and Hawkins's work, he also produced a really seminal piece of work on the risk and protective factors in Australia. And he worked with a number of the big players in Australia. And you can see Wendy Loxley's there and he's there, and Tim Stockwell. And the authors of that, there's about 20 authors of that publication. And there's a picture of it there. But that set up in Australia a summary of the evidence of the risk and protective factors and the programs that can be used to prevent alcohol and drug harm in Australia. So given that, how popular is CTC? Well, CTC is an international movement now. It's been going for approximately 30 years. You can see it's being used in North and South America. It's used in Australia. It's used in some parts of Europe. It's here in South Africa and also in small parts of Asia Pacific. So we can see currently countries that are using CTC. There are 15 countries. There are 4 countries adapting the tools and the framework to their country and their cultural setting. And there are another 5 countries considering and talking to CTC across the world about implementing it in their country. So in Australia, when John Timberoo brought it to Australia in the early 2000s, we've been now doing CTC for about 25 years. So there's a national CTC prevention movement in Australia. And these are some of the current communities that have used the CTC framework in Australia. And those ones I have listed there are LGA, so local government areas, so whole local government areas taking this approach and trying to change behaviour, specifically drug and alcohol, in their local government areas. So we have about 18 in Australia, and later on I'll talk about the randomised controlled trial that we ran, where we had 14 interventions, 14 LGAs, and 14 matched LGAs across Australia, and they were also in WA, Victoria, New South Wales and Queensland. So backing communities that care is 3 really big societies for prevention research. There's the Society of Prevention Research there on the left, which is set up in the US, and the European Society of Prevention Research. Both of these societies run conferences every year. The US one runs on the east or the west coast on alternate years, and the European one runs every year in some European country. It's coming up in Germany in a month's time, the European Society one. The US one usually runs during May. The reason I mention these is that every year in either one of those conferences, the international community for CTC meets and they share their ideas, they share community problems, community barriers, facilitators, new evidence, and we exchange ideas about how we can improve or change and implement CTC in better ways. More recently, we've developed an Asia Pacific Society of Prevention Research. So John Timberoo, myself, and a number of academics across Australia recognise that prevention is really underutilised. They don't have the same resources in the Asia Pacific region, and we're trying to help them use the learnings that we have to help them improve their communities. There was a book produced in 2019 summarising and synthesising all the international evidence. It's produced by Oxford United Press. It's about 250 pages and 10 chapters. If you're really interested in delving into the processes and the evidence, this is a great book to purchase. I did a Google Scholar citation search and I found about 150 CTC peer-reviewed publications and about 17,000 citations in the literature. And of course, if you like Wikipedia, there's also a Wikipedia Communities That Care website page. So how do we deliver CTC in Australia? Well, as I said, John Timberoo developed a not-for-profit company. So you can see there CTC Limited. That's a not-for-profit company registered with the Australian National Charities Commission. They have gift deductible status. They have a constitution and a board of directors, and the board of directors sets the strategic plan and manages the operations and management of a team, which you can see there below. So the team, which is really what delivers CTC to communities, has a CEO, some people, community relations officers, project managers and research staff. And they're operating through a number of MOUs through a number of universities, predominantly Deakin and the Murdoch Institution, and myself here at Monash. I have been the CEO for the last 6 years and also the research director for the last 6 years. We are looking to have a new renewal of some of the board, and we're looking to have new replacement of some of the directors. So after this presentation, if you're interested in joining the board or helping design the new strategic plan, you're more than welcome to approach me or someone and talk about that. So this is really what CTC as a company does. What it's trying to do is set up communities to form a coalition that are functioning and have the capacity to collect the appropriate evidence, interpret the evidence, and then in the end, select programs that are going to target the needs of their communities. So it's a very busy slide, but really what I wanted to focus on was that CTC as a company in Australia is setting up coalitions to become prevention-based communities. So how does it work? So we can think about a community having a vision. They want to improve the health and social emotional outcomes of their community. So this is the general timeline that we propose to communities. What we want them to do is collect data that identifies things that are elevating the risks and things that are protective factors in their community. Then do a needs and gaps assessment in their community and assess what gaps they have in terms of the data they may need to find and the programs and services and systems they can use to implement, or the programs that they might need to employ to implement. Then we help them develop an action plan, implement and evaluate it, and test the prevention strategies that they put in, with the idea of hopefully reducing priority risk factors, increasing protective factors, and then hopefully the outcomes of a reduction in problem behaviours and positive youth development. So that's nice as a sort of arrow logical step, but we all know that communities don't really work in a linear fashion, and we need to think about working with communities and coalitions in a more sort of iterative process. So we have this 5-phase framework, which we call the CTC framework, and it goes from 1, getting started, 2, to getting organised, 3, to developing a profile, 4, creating a plan, 5, implementing, evaluating, and then you go back to phase 1, and then you can start again. So what it is, it's a perennial cycle that communities can then either course correct, change their focus, or keep doing more of the same. So the first phase is about getting started. So we need to get local governments and residents and stakeholders to what we call a town hall event. And we need someone in that community to champion the idea of having CTC. And what we need is an agency to auspice the framework and the program. So what that champion does and that agency does is sends out messages or notifications to all sorts of people that are interested in youth and child outcomes. We have a town hall event, and what we're trying to do is make sure that the community understands prevention and public health prevention. So it's about what we call, are they getting ready, being ready for prevention. So it's about exposing the program, talking about the program to all the people, and then at the end of the night, people sign up whether they want to be part of the organising committee, the board, or any other sort of thing that they might have piqued their curiosity through the presentation. Once that's done, we get them to form a community board and form a key leader group. Now, the board is what comprises of anybody in the community, and it usually takes between 10 and 30 people. And the key leaders are the key people in the community that can give them access to funds, access to resources, promote the program, and when they're mixing with policymakers and key people, they're promoting the prevention and CTC framework approach in their community. So who can get involved as part of the board? These are the sorts of people and the groups that we have on our boards across Australia: local council, health, sporting clubs, youth and family services, Department of Education, justice, police, small business, religious communities. Anybody that's interested in child and adolescent outcomes can be part of that community board. And normally boards would have a little structure like this. They've got a community board, they've got an executive working committee, they're accountable to their key leaders, and they have little sub-working groups which might be working on specific things. And the working groups might be working on survey data, collecting the needs assessment, creating a community profile, all those things that I'll talk about in a moment. And we ask the community to have a community coordinator that drives the whole process within the community. And we usually suggest that that is about a 0.6 EFT appointment. So in terms of that, once they've got their board organised, what we need to do is get an understanding of what's going on in their community, and we call that developing a profile. Now, earlier on, you heard me talk about Hawkins and Catalano's survey and the idea that they identified these factors that are risk predictors and protective factors that are also predictors of problem behaviours and child and adolescent health. Well, we use that survey and use the evolution of that over the last 20 years to collect data at a school level. And what we do is we work with all the schools in a local community, because if you're working with all the schools in the local community, you're working with your target population. And then we get them to do their assessment of their local services and resources. And then they develop a profile of the elevated risk factors, protective factors, etc. So they're collecting the data on risk and protective factors that are predictive of these things. And we're working with students in local and primary schools. And what we usually do is one primary school, or 1 year level in a primary school, I should say, and year 8s and year 10s. Normally we need parents' consent, but in Victoria, the Department of Education has given us passive consent, but in other states we need parents' consent. And we have 2 surveys, one for the primary school and one for the secondary school, and it usually takes 1 class period to implement and fill out, and it can be done online or with paper. We ask them all these sorts of things about the behaviours that we're interested in, and then we prepare a profile or a report. And you can see from this diagram, this is an example of what would be in a report, that it's comparing lifetime alcohol use in their community with the broader region and broader Victoria. So what they can see is how their community is faring in relation to their broader region, but also the broader Victoria. So it gives them something to benchmark. And then we'll also give them something around the prevalence of risk factors and protective factors. So here's an example of the prevalence of community factors and family risk factors for a year 9 cohort. And you can see down the bottom, the brackets for C are presenting are are the risk factors for the community level, and the F is for the risk factors at a family level. And you can see here in this community, they're generally higher than the broader community, the broader Victoria. And then we'll also give them examples or analysis of how those risk factors and protective factors and behaviours are changing between the year levels. So here we can see a comparison between year 7, 9 and 11. And we can see predominantly for this community, as the ages go up, those risk factors in the family are also going up. So based on the work of Catalano and Hawkins that have identified things that are predictive of various behaviours, what a community can do is then identify what's prevalent, highly prevalent in terms of behaviours, and what's highly prevalent in terms of risk factors, and then identify programs that target those risk factors and those behaviours, and then implement a plan to reduce those. So that's what we do in terms of this fourth stage. We create a plan. They identify priorities plan and they create an action plan and also an implementation plan. So it's all good and well to have an action plan, but if you don't implement it with fidelity and properly, the interventions are probably going to pairs. So it's important that they identify what they want to do it, and they do that as a coalition, as a community, and with a shared objective. We also help them to identify meaningful reductions that could be targeted as a percentage change in terms of the behaviours and also the risk and protective factor changes. And then once they've got that, they can select their programs. One of the things that we've developed is the Community of Care Guide to Australian Prevention Strategies. And here's an example of one program called Peer-Wide Tutoring. And this targets academic failure risk factors and low commitment to school. It targets the protective factors of school opportunities for pro-social involvement and social skills. And there's also some information around who you can contact in terms of using that program or wanting to do it. And you can see from the text there, it's got some evidence around the evaluation, its monitoring, and some implementation evidence. There's also a matrix in the book showing you how you can sort of look at risk factors across developmental ages and stages in some of the programs. So, for example, if a community had high levels of community disorganisation and transitions and mobility, looks like there are 3 programs that they could possibly use. But if they're specifically interested in the 10 to 14-year age group, there's 2 programs that they could use, Friends for Life or Strengthening for Families. But Friends for Life are targeting the exact risk factors that are prevalent in their community. So this helps them to find good evidence-based programs to implement in their community. We're all used to working on the web, and a hard copy of documents aren't as efficient as they used to be. But there is also a web-based search engine, which was originally set up by the ARACI, the Australian Research Alliance for Children and Young People. It is now housed by by Deakin, and it's called the Seed Pod. You can log into that and you can search for evidence-based programs focusing on keywords such as risk factors and ages of the child or the group or the population you're looking at. It's actually a Deakin website at the moment, but you can log in and ask for login details and you can be sent login information to access that. So once they've identified the programs, of course, they need to implement that using the implementation plan. And they implement the priorities. So once they've done that, we then get to the last phase, and then we are back to collecting another round of data. And what we're hoping to see is changes in those risk and protective factors and changes in those behaviours. And then a community can say, okay, we want to bring those down more, so we're going to do that again. We might be implementing more programs or change programs, or we might change our focus. And usually we ask communities to select at least one universal program, one program that targets the whole population, some selected programs, so programs that are targeting kids that are already showing signs of elevated risk, and then some indicated programs for those kids that are already in the sort of moving towards the treatment phase. So in terms of the evidence, what have we got? The US evidence, they've done quite a number of trials. They've done quite a lot of natural experiments rolling out the program in America. I think there are 11 states in the US and I think about 66 communities using CTC at the moment. So they've done some randomised controlled trials and they've done some longitudinal studies. And they've produced evidence showing that they can reduce alcohol, tobacco, cannabis, and mental health. They've also done a cost-benefit evaluation. Just moving something. And you can see that's the Kalinsky paper there at the end. And their cost-benefit identified that CTC saved $12.88 for every dollar invested in averting alcohol, other drug use, and antisocial behaviour. So by any standard, that's an excellent cost-benefit result for a CTC, for a prevention and public health program. There's another place in the States called the Washington State for Public Policy, and you can see the website down there. They look at, they're an independent organisation set up in Washington State, and they evaluate the impact of social programs and the cost benefit and make actual recommendations to the Washington legislature. So here you can see on the, this is actually a screenshot from their website, from their search engine, and you can search for a whole lot of programs. You can see there, I've searched under all research areas, but you can look under criminal justice, child welfare, mental health, public health and prevention, a whole stream of things. You can see there that they've looked at the literature in January 2019 and done a literature review, and they've done a cost-benefit analysis, and their overall conclusion is that overall, when we model the confidence intervals with all of the studies that have been published around CTC, you are probably going to get a $5.69 return on investment for that program. And with their simulations, you see that last column is 87%. They're saying with an 80% simulation chance that every program, there's an 87% chance that your program will return a cost benefit. So that's the US evidence. John Tibaru brought the program to Australia in 2000. We piloted the program in 4 communities. And we ran at least 2 cycles for some of those communities across those early phases. So this is here, Mornington Peninsula community, and here's just some of the results that we produced as part of that pilot. So here, this is the Victorian trend in alcohol ever use. The middle line is what we're looking for. Those 2 outer lines are the 95% confidence intervals. Here's communities that care. It was above Victoria when it started. It was still above in 2008, but came down and was trending down. And then in 2012, came below or just equal to Victoria. Similar story with cannabis. It was much higher in year 7 than Victoria, but then came down in 2007 and stayed down, but trajected slightly more in 2012. Tobacco use, a similar story. And then early initiation of sex in year 7, above Victoria, and then almost the same at about 2012. So that was some of the pilot work that we did, and that gave us confidence that we could implement the developing and the formation of coalitions in Australia to work together to try and produce public health change, population level change. So we were funded as an NHMRC grant and an ARC linkage grant to undertake a randomised controlled trial. And you can find some of the details of those trials in these 2 publications. And what we were trying to do is build coalitions, make sure the coalitions worked effectively and could become public health prevention evidence-based communities. And what we were trying to do is promote the NHMRC drinking guidelines in the community, that young people would not drink before 18, but before 15, and preferably before 18, as the guidelines recommend. We also worked with the community on marketing the guidelines and a series of lesson plans across schools. And we also worked with local alcohol sales shops to ensure that they were performing best practice and not selling to minors. So overall, we identified through a couple of publications that we had parents having a better understanding of the NHMRC guidelines. We had more adolescents not intending to use alcohol before 18, and we had fewer adolescents not drinking alcohol before age 18 compared to the control group. We've also done some longitudinal studies using the data that we've collected across the 20 years that we've implemented communities of care in Australia. We have used administrative data here in terms of crime statistics from Police Victoria. And what we looked at was the crime trends in 2010 to 2019 and compared them to the CTC communities in Victoria. And what we found in the communities of care communities that there was a reduction of 5% in non-violent crime and a 2% in annual reduction of violent crime. And it equated to about the reduction of 800 violent crimes per year in CTC communities. We've also done an evaluation of the injury. So alcohol, drugs have a secondary consequence of accidents and injuries. So what we are interested in is, did we bring down injury and accident injury in those communities? So we did, working with the Monash Accident Research Centre, we did this study looking at the training effects, building coalitions to reduce hospital-admitted injury incidents in Victoria. And what we found was that in the communities of care, we had an 8 to 10% reduction in all hospital injury admissions and a 9 to 10% reduction in unintentional injuries. We've also done a cost-benefit analysis. So I was talking before about the US having an evaluation that identified $12.88 return on investment. We've just started doing the economic evaluation for the things in Australia, and this is a publication that only came out last year, and it's looking at the cost benefit for those 4 pilot communities that I presented those figures on. And what we've come up with here with those 4 pilot communities in the short term in terms of alcohol-related harm, that there was a $2.60 return on investment. And that was largely contributed to reductions in crime and violence. So we still have more work to do around the long-term investment and working with with the other communities. But all the evidence so far is pointing in the direction that we are returning an investment for policymakers and communities. So the last thing I wanted to cover was the idea of mental health. CTC does address mental health. We haven't actually addressed it specifically at the moment, but we know we have brought some reductions down in some communities. The Victorian government at the moment has invested, I think, nearly $218 million over 4 years to support student mental health and wellbeing. And $200 million of that has been invested into, over 4 years, into creating a mental health fund and a mental health evidence-based menu. So you can access this menu here at the school mental health menu, and it only lists evidence-based programs. And schools have an access to a minimum of $25,000 to use to spend on evidence-based mental health programs in their community. So Communities That Care is listed on that menu as an evidence-based program. Now, it was a very high screening process to get into that menu, and we met all those bars, we jumped all those bars, and we're now on there. So what we are trying to do, given that we have a framework and a process that works, we're offering a variation of the CTC community approach to help build mental health prevention in the school setting. So what we're wanting to do is schools to use a similar approach in terms of understanding and preventing mental health problems, but also working with their broader schools and broader community and building an evidence-based and using evidence-based programs to bring down the mental health problem in Australia. So, whoops, there you go. You've got a kitchen tour, a cook's tour of what CTC is, how popular it's been in Australia and across the world, how we deliver it across Australia, and how it works, and what's the evidence not only for Australia, but internationally, but specifically America. I also then just ended on in terms of what we can do in terms of using the framework to create population level mental health change, because we know mental health is such a big problem, and no matter what we're investing into treatment and sessions for psychologists, we're not moving mental health at a population level. We need to seriously think about using this approach or a systems public health approach to improving mental health outcomes. So I started off with this seminar, this webinar, asking the question, can we change the behaviour of populations? I think, and I think you should agree with me, that we can. We stand on the shoulders of giants. There are great people that have preceded us and have done really important work. We can stand on their shoulders, see further, and do much more work than they have achieved. And that's what every generation should do. It should see further than the previous generation before. We do that if we do a strategic and take a coordinated approach, working with coalitions, getting people to get shared ideas and work to a shared objective together. Often communities are working at cross purposes because they're not talking to each other. So a coalition approach can get communities and stakeholders looking and pointing in the same direction and strategizing and stepping out what they should take strategically. And we do that by taking a multi-component approach and using an evidence-based program approach. So this is our website. You can go there and you can have a look around. It's got some details about the framework and the program, the board, all those sorts of other things. That's our address. If you'd like any more details about the program and you want to have a chat, or you're interested in thinking about, you would like to think you've got something to offer the company board, or you'd like to help us in formulating the new strategic plan, you can contact either myself or John with one of these email addresses. So that brings me to the end of the presentation. I think now we can move to Q&A.
Thanks so much, Bosco. That was a really great overview of community care and the incredible work that's been done over 30 years. Just to remind people that if you have any questions for Bosco, please pop them in the Q&A box, which is at the bottom of your Zoom screen. Can I just ask first, just before we go to the main questions, just some practical, pragmatic issues. So can you just talk about that overview around sort of communities joining coalitions? Sort of what's the reality of that? How do communities join? What's the process been like? So what are the main questions community ask? When people put their hands up to help, sort of, how do you take them through the whole process, and what does that actually look like?
So I think the key thing is that, getting ready, that first phase. So it's about giving them an introduction to what is prevention and public health. And what we've found is that most people are generally motivated by goodwill. They want to do good things, but they're often driven by the funding and circumstances of their own organisation. But if they're working together, they can find that they actually can work and achieve a lot more. We've had communities that have been a breeze to work with, and we've had communities that have been real sticklers and have taken much longer. So that's why those timelines that I put at the bottom, you can get through a cycle in 2 years, or it can take you 5 years, or, it can take you a bit longer than that. But it is, you're dealing with people, you're dealing with organisations, so it's not always a smooth process, but it is a matter of bringing people along with you and making sure they're ready. So I'm not sure I've given you an exact answer or a perfect recipe there, Dan, but what I'm just saying is it's a negotiation and it's a relationship building exercise.
No, thanks so much. And I think that this question sort of links to that that we have from Joe, which is around the community population sizes that you work with. Is community care sort of predominantly aimed at larger LGAs, or sort of smaller regional communities? Is there an ideal size or scope?
No ideal size. It's just a community. Okay. So we've had smaller and bigger communities. So we've worked in regional areas which have smaller communities, but they're spread out wider. But we've also had smaller communities. So like, it's interesting, in Mornington, the Mornington Peninsula, that's quite a big LGA. And what we ended up doing, because it was such a big LGA, there were actually there were sort of 6 like local council groups in that space. And what we formed in the end in trialing this process was we actually had 6 coalition groups in there, because they knew their areas well, and they worked and they created their own action plans and implementation plans. So, it is a flexible framework, and it doesn't matter on the size. It's the matter is that you want to be capturing the groups that you're working with, you're measuring them effectively, and the programs that you're getting or using are reaching that group.
Thanks, Bosco. Got a question here from Rowan around, you talk very much about sort of the international sort of an Australian experience. Sort of, can you talk about the differences in barriers to implementing community care and all those interventions, evidence-based interventions in those different settings?
Yeah, look, I think, Australia's sort of far behind the US in terms of its list of evidence-based programs, but we've got a reasonable amount. John Timber has been, one of the one of the giants bringing these programs across to Australia to make them implemented and enculturated here in Australia. But sorry, what was the question? I just lost my thought then.
The question is just about the challenges in implementing these things across different countries.
Yeah. So there are differences. So we do help communities in terms of their implementation plan, that they can modify and change things to culturally adapt things, but you've got to stick to particular guidelines, and that's all around implementation and fidelity, which is all part of that training in phase 4. So again, it's all about capacity building and building their understanding of what they can and can't do in a good prevention public health approach. So yes, there are things that don't work and you have to adapt them. And there are also things that we brought over from the US in terms of the training that haven't worked in Australia. So we were using a lot of their resources at the start, and a lot of the communities would say, gee, they've got American pictures, and we use videos because they've got a lot of online training, and they say, oh, they're just American. And I used to think the videos were super in terms of content because they were really pithy. But they felt just the look and feel of them just weren't Australian. So we stopped using them. So you have to adapt and you have to feel the way for the community, but there are rules and frameworks that you can use to be flexible and adjust that.
And there are great examples, but are there sort of interventions that just don't work in different countries, or is everything, all the evidence-based approaches work similarly across countries?
Well, I don't know if I can answer that question, Dan. So the interventions, so the evidence-based programs, that's not the work of CTC. That's the work of other, people probably listening to this seminar that are developing programs. So we are identifying the evidence program. What we're wanting to do is that they stick to the CTC framework and use the guidelines and the guardrails to implement programs, assess programs, and collect data. That's the main thing. But I suppose there are programs that don't work, and that some communities find are a bit of a waste of time. So that's what they would do with their second round of data collection, and also in terms of the facilitation and training that CTC Limited is giving them. They can talk about what's going on, the program's not working. Okay, all right, we might need to change our action plan, or we might need to change the way we're delivering this program. So it has to be some flexibility, but we need to keep it within a prevention science framework.
Thanks, Bosco. We have the question from Clive, which I think is close to your heart. Can you explain the importance of only using evidence-based programs to support addressing issues in young people?
That's an excellent question, and a question that comes up with every cycle of CTC. So what we do is, yes, we want people to use evidence-based programs, but the assumption there is that everything's already there, and then we've got programs that address every need of every community, which is false. So what we want to do is implement programs that work. Don't implement things like saying, oh, we want to get the youth together and we'll get them to paint a bus shelter because the bus shelter gets them all bonding together and then they'll all feeling nice and warm and won't use alcohol and drugs. There's no evidence behind that. It's a nice intuitive feeling, but it's no evidence. So we want them to implement evidence-based programs. But of course, there might be some programs that the community has been developing, or there is something that's emerging. And so we can implement that into the action plan and the implementation plan. But as long as we build the right guardrails and framework around it to make sure it's being implemented well, it's grounded in good research and evidence, and we collect the appropriate evidence to evaluate and implement, to evaluate that as part of the whole process. So no, you don't have to implement only evidence-based programs, but that's just the easiest thing because it's easier for communities to take something off the shelf.
Thanks, Bosco. We've got a couple of questions here around sort of other outcomes. So a question around housing insecurity. Have you looked at any outcomes in terms of that, in terms of CTC?
That's a good question. And there are questions in the CT surveys about housing. But I don't know if any community to this point, and that's an excellent suggestion because it is a big major problem and a big risk factor. But, was part of the work that John Timbrew has established since 2000 is that we've worked with over 260 LGAs across Australia over that 20-year period. We've got the changes in risk and protective factors of these communities, and we can see some of the changes like housing and housing insecurity that have changed. So communities can access some of that data. They can come to CTC and we can help them work out what's the profile of their community and then target some things like housing insecurity and the behaviours that might be associated with that.
Thanks, Bosco. Got a couple of questions around the practical nature of CTC. So can you just talk about the financial or resource commitment in sort of working in CTC, and who provides that? Who provides the financial support?
So what the financial it costs? So there's 5 phases, as I said. So the 5 phases for CTC, and then CTC Limited provides the training for each of those phases. And each phase has sub phases. So I might have 2 or 3 phases. So say in creating a profile, it's the needs and assessment phase. Teaches them how to do that. Now each phase and sub phase costs the community like $1,000 or $1,500 or something along those lines for the training, and overall for a full 5-phase cycle and all the components and all the technical assistance throughout it and some assistance after it is about $80,000 to do the whole thing.
And Bosco, who funds that?
Well, the community has to fund that, or the coalition has to fund that. So
did you talk a bit about sort of those experiences in communities? So what's the sort of different models that maybe communities have in terms of resourcing that?
So often, usually, what we've had in the past, we've had a lot of local governments implement CTC. So what local government do is implement it into their budget and their strategic plan. So what they need to do is that's where you need the key leaders to action and support and promote CTC. So that's why it's this big coalition approach. Everyone's got their role. So what we've found is that some people will get funding from their auspice agency, some subcomponents of some agencies that are in there, and they'll also apply for small grants that can assist them in there. So that fund doesn't need to be paid out up front. It's paid up in steps as you go through each of the phases. So it could take them 5 years to pay that money, or it could take them 2 years. So it's a matter of moving through at the pace you can and at the resources that you have.
We have a question here also about sort of, does CTC work in communities where there are, or very few, on the ground local services, particularly areas in growth corridors or regional townships? Is there sort of minimum?
When you say, I'm not sure what you mean by few people in the community, you mean actually population or staff?
No, on the ground services.
Yeah, no, I don't know if we've actually covered across that, but we have worked in a few communities like that are emerging in the emerging corridors, like the name's just escaping me now. We have worked in some growth corridors, yes, but I've got a bit of a mental block. And so again, that's trying to find and bring in services that helps that community, because that community needs to build up those services and resources if they're going to respond to the needs of their community. So it might be a slower process for that community, but it's important that they learn that they're trying to build prevention capacity in their community, and so building in services and resources should be part of their strategic direction.
Thanks, Bosco. Can you, another question here is around successful prevention strategies. Can you give some examples of the successful strategies that you've used in CTC in Australia or elsewhere?
So I think in Geelong is one of our flagship communities, and they've been using the program Strengthening Families, which has had some great results over there. So I can't list a couple off the top of my head. So then there's also, we've done the social marketing in terms of the NHMRC guidelines. We've done supply monitoring, so monitoring the sales to alcohol to minors. There are some school programs looking at bullying and tutoring and mentoring, and they're all listed. I just can't remember them off the top of my head. And if John is online, he might be able to sort of put him in the chat. So yeah, there's a number of, but if you go on, if you go online, you'll be able to find them.
Thanks, Bosco. Question here is around how does CTC work with other sort of prevention or capacity building frameworks?
Yeah, that's an interesting point. So I remember when we implemented in Ballarat, Bendigo, sorry, one of the first questions to the presentation I made at the town hall event was, so what's the difference between this and collective impact? Well, it's very similar to the collective impact model. And so what we did was we worked with that community saying, this is what we're doing. You can bring your collective impact understanding, but we want to make sure that we're doing the right things at the same time. So there are a couple of models out there. Collective impact is probably one of the ones that is most similar to it. Collective impact was actually based on CTC. If you go back to its first literature, it cites CTC. So it's a matter of working with them. And sometimes communities will name their approach. They won't call it CTC. They might call it something else. Now, I think in Ballarat, they called it strengthening generations, but it was the CTC approach. So it's about sort of using what you've got, but making sure it's consistent with the evidence and a public health prevention framework.
I've got a question here, Bosco, about stigma. So what are
Yep.
your thoughts around sort of preconceived negative attitudes and stigma for some people that are facing challenges in the community? How does CTC work with that, or how they address that?
Yeah, that's a good question, because one of our communities was Warrnambool. And so when we collect data at phase 3, when we're collecting a profile, what the community sometimes does is it does a big media launch and it talks about the problems in the community, or, talks about CTC being a real initiative. And it might say, alcohol consumption's up, illicit drugs up, school mental health is just at a worst level it's ever been, or whatever. But what we found was you've got to be really strategic about the way you do that, and you've got to take a sort of strengths positive based approach in terms of promoting that, because what we're trying to do is improve outcomes. Because the coordinator that we had at one time in another community was promoting it probably too hard, and then it actually had a bit of a backfired, and then we had to do a lot of repair work because the community said, well, what's going on here? The community is a disaster. What are you doing? You're talking about these people that have got problems. You're supposed to be helping them. So it's an important issue that we've got to manage, stigma, and you've got to manage that carefully. And so that's, again, part of that early training about talking about stigma, managing those kids that are already, at the pointy end of the spectrum.
Thanks, Bosco. Just John's just put in the chat.
Yeah, good.
Popular programs selected by the communities include Smart Generations,
Yep.
School and Community Adolescent Alcohol Use Reduction, Tuning Into Kids, which is across the Yarra CTC, Triple P.
Yep. Sorry, that's great. Yeah. Good on you,
Climate
John.
Schools.
Yep.
Lots of examples. Do you want to expand on any of those, sort of, just to let people know what those programs are?
So the Smart Generations was the program we delivered as part of our randomised controlled trial. So I gave you an idea that it was about promoting the NHMRC guidelines, working with parents to set a rule around not providing alcohol until children are 18, working with sales in the community, and having a strategic, dedicated lesson plan and education approach in the schools. Triple P is about positive parenting program, which is about improving parenting practices, so helping parents manage children, manage family conflict, and deal with issues within the family during the developmental stages. What else is in there? Climate Schools is a drug education program which works using drug education curricula and programs within the school. What else did you say there, Dan?
I think Smart Generations.
The Smart Generation was the first one I said.
Tuning Into Kids, sorry.
Oh, I'm not sure I know enough about that one, but yeah, that you can look that up on the web quite easily.
Thanks, Bosco, and thanks to John, and shout out to John for all his amazing work in this space.
Yeah.
Just a really good question. Obviously, a lot of focus at the moment is around how to involve lived experience. So, do you want to talk a bit around CTC and lived experience? Do you promote it? How do you address issues like trauma and other issues when we're touching on that stigma issue?
Excellent point. Yes, and that's really where the coalition really comes into its own. It's really important, and what we do have on those coalitions are people, and that's probably what I left off that list, so I do apologise. People with lived experience on that board, so they bring their lived experience to it. We also are looking for people on part of our CTC Limited board to have people with lived experience on there as part of the refresh. So we recognise that lived experience is a really important part, and as part of the training, we've integrated lived experience into forming the community coalitions.
Thanks, John. Thanks, Bosco. Just we're almost coming to the end of our questions. You've done an amazing job. Can you might just talk a bit about your reflections? Sort of, you've been involved in this for a long time now. What's the most, I suppose, what are the things that you've learned across that time, and what's the most impressive thing that you take away from this whole initiative?
Well, I think Public health and prevention, it's the long game. You got to be in it for the long game. It's not for the faint-hearted, but the rewards are phenomenal, because what you see is population change. You see whole communities move. You see, the dial really shift. I think what's been impressive for me is being able to work with these great people that have formulated this program and have, synthesized it in such a way that has really given me a career and an opportunity to make impacts not only in Australia but across the world. So I think I invite people to take up the challenge of implementing public health prevention, getting involved in the space, and doing this sort of work.
Thanks, Bosco. I think that's a great way to end. Just to say that John's also written in to say a tip guide for getting money. So money has come from LDATs, Crime Prevention Victoria, TAC, Rotary Clubs, Regional New South Wales.
Yeah,
there's lots of, I suppose the answer is lots of people have been happy to support it. And I suppose getting support from you guys in terms of how to put those granting submissions in, obviously.
Exactly, yeah. So the local drug action teams, which was funded by the Australian Drug Foundation, most of their local drug action teams were using the CTC framework. So that's an excellent point. So there's lots of sources out there for communities to be funded.
Brilliant, Bosco. Well, you've certainly answered lots of questions on CTC. You've given a really great overview. We've exhausted all the questions that you've comprehensively answered. So given that, we'll give everyone a bit of time back to make sure they build prevention into their day and go and give themselves a nice bit of a rest before their next commitment. And I just want to finish by just thanking you, Bosco, for a brilliant presentation and for the work you do, and for everyone who's been behind CTC for such a valuable contribution to the community. That ends our webinar series. The video will be available for this talk on our website in the upcoming week. Please promote it through your networks for anyone who wasn't able to meet today's presentation. Please sign up to our Talking Point seminar series, which we do monthly, and we hope to see you at our next presentation. So from all of us here, good afternoon and thanks for tuning in.